Hello, and welcome to POMA Does, a podcast produced by the Pennsylvania Osteopathic Medical Association. We provide a voice for osteopathic medicine and share insights on issues important to osteopathic physicians, residents, and students, as well as those who embrace the osteopathic philosophy. POMA's mission is to promote the distinctive philosophy and practice of osteopathic medicine in Pennsylvania for our members and their patients. Thanks for tuning in.
Hello and welcome to the latest episode of the POMA Does podcast series, sponsored by the Pennsylvania Osteopathic Medical Association. My name is Alicia Green, and I'm a general surgery resident at Penn State Hershey Medical Center. Today, we are going to explore resident unions. I'm privileged to be joined by Dr. James Latronica, who will be teaching us about resident unions, and my co-resident, Dr. Jessica Almala, who will be assisting with questions. I'll give you both a chance to introduce yourself, starting with Dr. Latronica.
Hi, thank you for having me. I'm Jim Latronica. I'm an assistant professor of psychiatry and family medicine at the University of Pittsburgh School of Medicine. I treat behavioral health and substance use disorders with 100% of my clinical time, and it's a pleasure to be here.
I'm Dr. Almala. I'm a second-year general surgery resident at Penn State Hershey Medical Center, and I'm also excited to be here to talk about this exciting topic.
Thank you both for joining today. Since the theme of this podcast is about advocacy and organizing, can you tell us some broad ways we can accomplish this?
Yeah, absolutely. I would like to maybe turn this around first, since we're talking mainly about residents. If I could ask both of you what sort of sparked your interest in this topic or this podcast. Is it a broad theme? Is it considerations at your respective hospitals, if you're comfortable sharing that type of info?
Yeah, I was interested in this because I didn't even know that resident unions were an option or were out there. I had no information on it, essentially, in general. I think it'd be interesting to learn a little bit more about how this could fit in with our resident picture and how this would change my life in residency and, maybe better it.
I agree with Dr. Almala. At Penn State, we don't have resident unions to my knowledge. So I am interested in the topic, learning more about it and learning how we can become involved nationally and also locally at our own institution.
Sure. And I hear that a lot, just a complete lack of knowledge. And also I'll lead off with, at any time, this is conversational. So if I really start to get going, feel free to interrupt or redirect. That's what I'm here for, is to answer questions. So getting back to your question, broad themes of advocacy and organizing, there are lots of ways to do that. Medical societies like POMA, I don't have anyone in medicine in my family, and I would get these, letters from POMA or AOA or Pennsylvania Medical Society. I didn't really know what any of that was. I didn't have any exposure, but POMA is very involved and very efficacious in terms of advocacy and lobbying. So getting involved with your county, state, national medical organizations is a great way to advocate both for your profession and your patients. There are also community groups, things like free clinics where physicians of all different backgrounds tend to work. There are local government initiatives. So a broad theme of advocacy, there are many different ways in which you can get involved.
Great. Thanks for that, Dr. Latronica. Another question. So in your experience, can you talk about some advocacy efforts at the medical society level you've seen POMA or other groups engage in that have made a significant difference?
Yeah, and I think that's important to point out too, because a lot of this stuff happens sort of behind the scenes, and especially when you're a student or a resident, not that attending physicians aren't busy as well, but there's a different level of investment that you need in the actual day-to-day work. So one very pertinent example is Senate Bill 225 here in Pennsylvania, which has been worked on for well over a year. It's a large prior authorization reform bill. So you're both residents. I know you've certainly heard the term prior authorization. I know we have at least one surgeon on the call. And so there's probably been a time in your clinic, or you've heard an attending talk about a certain procedure that was delayed, or you needed to jump through hoops in order to get your patient the care that they needed. And this extremely large prior authorization bill has a lot of positive changes and has been overwhelmingly supported by essentially every medical society in Pennsylvania. For my end, I can tell you, I do addiction medicine. That's my subspecialty, and that's what I do 100% of the time. The initial language in the bill that revolved around prior authorization for medication for opioid use disorder, MOUD, things like methadone, buprenorphine, and naltrexone. We thought at the Pennsylvania Society of Addiction Medicine, where I'm public policy chair, we thought those changes were essentially meaningless in their initial form. And so Andy Sandusky asked me about it just casually because he knows of my subspecialty. And so I worked with him in the very last minutes of this bill. He worked on it for far longer and in a far broader fashion than I did. But that's an example of, I have this subspecialty interest. Someone at POMA knew about it. They thought that the language kind of looked a little iffy. And so that was a way that I was directly able to help my patients and I think my colleagues across the Commonwealth.
That's great. So it seems like we have quite a few ways to affect change within medical societies. You mentioned unions being a part of that. And as Dr. Amala and I stated in the beginning, we were unaware that physicians had unions, especially at local institutions. So we were wondering if you could talk a little bit more about that.
Yeah, absolutely. And I should here get some disclosure or disclaimers out of the way since I'm on the board of POMA. POMA doesn't have any official policy on any physician unions. So what I talk about here isn't necessarily an endorsement. It's not advocacy. It doesn't reflect the views of the POMA board or its members. And also, I did previously work with the largest national resident union, the Committee of Interns and Residents. When I was a resident, I was never employed and never received compensation. I'm no longer affiliated, but just in terms of transparency, so everyone knows what we're talking about, I wanted to start with that. In terms of the specifics of what you're asking, a very sort of cut and dried version of how anyone can form a union outside of a couple of professions, domestic workers and farmers. If you have 2 employees and a boss, you can form a union. There are anti-monopoly statutes that exist that refer to physicians' abilities to unionize. So for example, if you have a private practice and you own it and you're in charge of hiring and firing, it is correct that you would not be permitted to form a union. However, we know that whether it's in Pennsylvania or nationally, far more physicians are now what we call employed physicians, meaning employed by a hospital system. So basically, if you have a boss and you're not in charge of hiring or firing, and you have more than one coworker, you can form a union. How it works when it comes to residents is the national union, the Committee of Interns and Residents, which is a division of the Service Employees International Union. You may have heard of the SEIU. They're the national union that is legally recognized entity allowing resident physicians to collectively bargain.
Interesting. So I think one of the things that people think of when they hear the word union is the word strike, something kind of their mind goes right to. And obviously there are some safety concerns when it comes to patient care. Can you discuss this?
Yeah, I think that's definitely the case. And when I was a resident, that was something that came up immediately. And part of that is mass media portrayal of unions and the fact that that is one of the tools in the toolbox, so to speak. But as someone, if you would ever speak with someone at CIR, what they would tell you is that the primary goal of any union is to have a seat at the table. There was a time prior to the 20th century when workers did not enjoy these rights. And there were, in fields like manufacturing and things like that, violent history of worker struggle. And so the idea of a strike as sort of being synonymous in people's heads with unions is correct in some surface way, but that is a last resort because it tends to be extremely disruptive. In medicine especially, we have a duty to our patients. I will note that the last resident strike was in the early 1980s. If there is a time that comes where concerns aren't being listened to, the collective bargaining arrangement isn't being honored, there are other ways in which those concerns can be addressed. I would also note that healthcare workers in other fields have gone on strike. When I was still a resident, a hospital system in Western Pennsylvania, nurses went on strike. And I don't want to understate how critical of a decision that is. And whether it's nurses or in the 80s, the residents went on strike, there are serious considerations. But ultimately, the idea is that what we need in order to safely and effectively treat our patients, at some point it's outweighed by the need to effect that change quickly. And whether in the case of nursing, it's staff shortages and refusal to hire more nurses so that nurses are covering way too many patients and it becomes unsafe. So it's an extremely delicate balancing act, but in the world shifting back to physicians, very uncommon and hasn't happened for quite some time. And remember, the idea is to have a legally recognized avenue to air your concerns and to be able to have a say in what your job looks like.
Since this is an area that many residents aren't familiar with, what would be your recommendations for go about forming a union? And is this something that you typically see through just one program joining a union or an entire institution of residents from different specialties?
Yeah, so that's an important consideration, because how it tends to work is your ability to form a union is based on who's writing your paycheck and who gets paychecks from the same group or payer. So, for example, at a larger institution where you have a bunch of different specialties, generally you would need all of the residents to sign on, and we can potentially get into that process. For example, I think it was 2 years ago now, the University of Massachusetts, all of their residents unionized. And so you can imagine, surgeons and family medicine doctors may have very different views on what their day-to-day should look like and what compensation can be. And so that certainly does pose a challenge in terms of how you can all align with the same interests in mind. Just to be a little more conversational, and you don't have to disclose specifics or names, but, can you think of any topics that keep coming up, or that residents, whether at your program or other programs, things that keep coming up time after time that you've heard?
Yeah, so a lot of, resident wellness issues such as time off, maternity, paternity leave is always a big topic of conversation, especially in residency, because we seem to get a little bit more limited time off than in other areas.
I would say mainly work hours would be the main concern that I hear of most often through program.
Yeah, those are similar. Some of those things we actually rallied around when I was a resident, the idea of maternity and paternity leave, because depending on the program, there are mechanisms in place for residents to take time off for maternity and paternity leave, even via ACGME, but they're not always explicitly clear or understood by programs or honored in the way that they might optimally be. And so, we talk about physicians dying by suicide at twice the rate of the general population. We talk about burnout. We talk about resident wellness. And you have this experience during, one of the most stressful times of your life, someone who's having a baby. And I agree. I think that's an excellent point to rally around in terms of concern, because it is so important. We know that bonding time is important. We tell this to our patients, right? If they have prenatal visits, pediatrician checkups, we talk about that. And so to answer your question, the idea of finding something common that's broad and simple to digest and difficult to pose. For example, I think it's really hard. I understand, especially surgeons, you have to have X amount of procedures, and there is an element. A lot of programs are moving to 7-year programs in surgery, I've been made aware. So we give up a lot of our 20s and in some cases early 30s. And so honoring the commitment that we're making by programs honoring our family life, I think is extremely reasonable. I'd also note that the CIR specifically has a resident Bill of Rights, which is basically 9 points that include broad, very reasonable considerations. When we first contacted CIR, they told us about this resident Bill of Rights, which you can find at anewrealitynow.com. And it's very reasonable things: a living wage, no more than 80 working hours per week. We know that's the requirement, but we also know it's self-report, and there can be pressure because of those power dynamics to underreport your hours. Appropriate time off for being sick and parental leave, transparency and due process, mental health services, things like that. So when you're thinking about why you want to form a union, I think it's good to have concrete examples of what changes you want to affect.
Definitely. And I think those are a lot of good examples that come up a lot, at least amongst conversations between residents. So that was really helpful. Another question for you. Programs generally have a GME committee. that residents are a part of. So doesn't this kind of serve the same function as a union? How are they different?
Yeah, I think participating in your graduate medical education committee or whatever it's called in your institution is important, because I think, there's definitely something to be said for, following the procedures of your hospital and going up the chain of command, because not every request or every consideration is going to be denied. And if things can be altered for the better for you folks in your residency, then that's a perfectly reasonable way to do it. And it's good to participate regardless. What I'll say in terms of the difference is, and you're all aware of this for some of the medical students who may not know, who might be listening, there's, residents, when you're a fourth year medical student, you apply to participate in the match, which in ways is like a job lottery, right? You apply, it's semi-blind. It does favor residents in terms of their selections, but there's an element of uncertainty to where you're going to end up. And furthermore, when you're actually accepted during that stressful period, when you're waiting, you're finally accepted, the contract you get is essentially it. You sign what you get. You can make alterations and see if they'll honor any of them, but the power dynamics are shifted significantly in favor of hospitals as opposed to residents. Some of that is the structure. I'm not necessarily assigning blame here, because in some ways assuring uniform, safe, and effective training does require some trade-offs. But when you're talking about your right to be an employee under the National Labor Relations Act, things like GME committees and the types of contracts you sign are unique to this profession, in that there's just not a lot of leeway and not a lot of autonomy.
I think those are good points to bring up as well.
When you folks signed your contracts, did you read through them? Did you make any changes? Did you think, oh, I wish this was different? Were there any aspects that you thought, this seems a little different, I wish I could change this?
I don't think so. Not on my end. I was pretty happy to match.
Right. And exactly.
Into a surgical residency. I didn't really know there would be even an opportunity to, go against what the contract offered. Right. So I was happy to read through it and sign it, and just thought those were, our
that's what it
obligatory things that we would have.
I assumed there was no negotiating.
Yeah.
I wouldn't have wanted to do anything to compromise my position here. And yes. I definitely wouldn't have wanted, to be seen as like a troublemaker in the program by asking. And so I kept my mouth shut and signed the contract.
No, you're bringing up really good points, because it's so high stakes. If you go to medical school and you have all this debt and you don't match, potentially you can match through SOAP or scramble, after the match. But if you don't match into a residency, it can be really tough. There's no other graduate training leading to a job in this country that attaches to it so much potential debt and difficulty in employment after you're done. I'm not necessarily saying that, if you get into medical school, it should be a guaranteed jobs program, but our rate of unmatched residents keeps increasing. And so your point of, I don't want to make waves, I don't want to make trouble, I just want to keep my head down and get through, that is a very legitimate concern, because it's true. We don't have a lot of recourse, and we can talk more about that in a little bit in terms of potential risk, because it is, in my view, the number one barrier to physicians organizing both for themselves and for their patients. So I appreciate you sharing that with me.
As you're talking about the risks, what do you see as some of these risks for residents who form a union, and what would you caution residents to beware of?
So taking a slight step backwards in terms of the, how do you get started? I think finding a group of people who shares your views and interests is the number one thing, and starting to talk and forming something like an organizing committee or a wellness committee, and setting out a list of requests that you have or potential improvements, and discussing that with hospital leadership, potentially through something like a GME committee, I think is a very reasonable first step. Because like I said, 2 weeks of parental leave, and you say, well, really, when you think about what the attendings here get, is our paternity leave not as valuable, even though obviously there are training requirements? If you frame things in a way that is compassionate, in the case of paternity leave, evidence-based, I think that's a very reasonable start to have a committee, a wellness committee, organizing committee, whatever you want to call it, and starting there. In terms of risks, as far as, because this was my very first question too, when I was discussing this concept with my co-residents, it's like, well, what if they catch wind of this? What if someone gets mad? What if one of us gets fired? As far as the CIR knows, the Committee of Interns and Residents, they don't have any accounts of resident, firings or discipline simply for organizing. And it would be explicitly illegal under the National Labor Relations Act to do so. That's not to say that there can't be ways to potentially interfere with the average day of a resident should there be controversy within the program. Some examples were shared about stacking call days or changing schedules around and things like that, you might not expect from leadership. And to clarify, these were examples from the CIR, not my program. This didn't happen. So I think there are risks in terms of actually losing your job or having to transfer. They haven't found any of that since they've been, the national union. But we all know that with how stacked our schedules are and with how delicate the work-life balance for residents already is, it's certainly a consideration, especially if you're in a situation where, maybe you had to leave a program and go to another one. And that concept of, I really don't want to make waves. And that's what I say. You can be appreciative of your program and appreciative of the privilege we have as physicians, while also saying, I think things can be better, and I'd like to try to do that.
Do you see any other downsides to forming a union?
It's tough to say. Going back to the purpose of a union is fair and equitable contracts and ability to have a seat at the table and have decision making. Because again, those committees, those benefits or things that are honored are not necessarily written in stone, and they can be changed. So having the legal background, the legal support of the National Labor Relations Act, I think makes sense in a lot of ways. I will say, though, that my program, we did not end up fully forming a union. We had an organizing committee, and through things like letters and conversations, we were able to affect some change in terms of salary and how our call system worked with pagers. So programs may say, well, we were going to do those things anyway, or, you don't need a union to get that from us, just come talk to us. And it's true. But if it's in a contract that's backed by federal law, that it's there. And so in terms of downsides, there is risk. There is potential risk of, in-group fighting because residents may disagree. And so I don't want to editorialize too much on the risks versus the benefits. That's going to vary by program. But I would say, considering, how many people are on board, how unified are you? If you have 25 different things that 10 different specialties are concerned about and you really can't get together, I think that might be a clue that other avenues are worth exploring. But if there are things that come up over and over again in the same programs and they're not being addressed or remediated, I think that's a reasonable course of inquiry.
I think the stepwise process, like you talked about in the organizing or wellness committees, are a great place to start. Our last question that we had for you, are there any myths or misconceptions about resident unions that you could discuss with us that we should maybe keep an eye out for?
There are a lot, and it's not just specific to residents either. There is actually a national physician union for attending physicians, which I'm not involved with or affiliated with. I would say that the idea, we talked about the baseline, imprinted or burned into our brain that union equals strike. In the same way, I think the thought is that forming a union means you're mad at your boss, or you don't like your boss, or you're upset with your program. And I don't think that's necessarily the case. I think that program directors can or should understand the differences in power dynamics between them and their residents. There's also another element, though, because your program leadership potentially may be supportive and they may see a benefit to a resident union. Your hospital leadership, the C-levels at the hospital, are almost definitely going to be opposed. I wouldn't say necessarily by definition and not unanimously, but for example, there's never been a voluntary recognition of a resident union. Meaning, if you get a group of people together and say, hey, we want to create a union, your boss can say, okay, go ahead. As you can imagine, it doesn't happen very often. Hasn't happened for a group of residents yet. But I think this idea that you must be upset or you must be, this is the straw that broke the camel's back. I'm super mad and now I'm forming a union. Sometimes that's how it happens. It is a situation of we have no recourse left and we are upset, but it doesn't have to be that way. Because like I said, the idea is having a seat at the table and doing things preemptively when things are relatively stable and going well can ensure that what you have now is preserved in law via contract, of course. So, that's one myth. You're just forming a union because you're lashing out because you're mad. Not necessarily the case. I think, union can also be framed as a third party, that they're going to come in and make all the rules and they're going to write your schedules. And that's really not the case. They're facilitators. You talk directly with union representatives so that they can help you work on a contract, address that core list of concerns or improvements that you have. And they act as a facilitator between the hospital and you. They can often be framed as interlopers, that they're going to interfere with operations. In some ways, this is common across jobs, but especially at hospitals, the idea, our residency is a family. We're a family and we don't need these other people coming in and tell us how to do things. And my response to that is, well, I've never had to ask my family for extra time off when I was sick under threat of, PTO days. So while it's nice to get along with residents, get along with your program director, it's not a family. It's a job of work and it's a job of training. And so keeping that in mind, your safety in terms of burnouts and your patient's safety in terms of taking care of them, I think it's important to remember that having someone facilitate and to advocate for your needs so you can be the best physicians you can, it can often be reframed that way.
Great. Well, I feel much more educated regarding resident unions. So thank you so much for taking the time to kind of tell us more about this.
Yeah, I just wanted to mention the actual process. If it would go through, let's say you form an organizing committee and then you contact the CIR and say, hey, what are next steps? Well, what you have to do is you get together and they help you petition the NLRB, the National Labor Relations Board, which is sort of the governing body created under the National Labor Relations Act. The minimum amount of any workers who need to express interest in creating a union is 30% of the employees. So depending on the program, that might be quite a few people. It might be, very few people. And both of those have their own challenges. The thing is, they're not going to call for the signing of cards, which is the step after that you submit to the NLRB so they can count, unless you have a much higher percentage. Because as you can imagine, as time goes on, if you would continue on with the process and get towards forming a union, the NLRB does make the employer aware. And so there are different strategies that can be used in terms of how such formation might be opposed. So really, if you're thinking about this and thinking about it seriously, you would like to have 70 or 75% or more percent of whoever's in your workplace on board and fairly solid. Because when the next step comes, the final vote, you've probably heard some of these about, Starbucks unions that have popped up. You need 50% of people who vote plus one. So just over 50%. So if you have 30% and people fall off, things like that, then the campaign kind of blows up. So functionally, this is very surface level details. There's more of it, but you really have to have unity. But I also think it goes back to your point about, is it just because you're mad at your boss, or is this just because you want more salary, which isn't unreasonable among a list of other things. But, if you say, hey, look, we have 80% of people who are residents at this hospital saying these are changes that we'd like to see and we haven't had them addressed, I think that goes a ways towards legitimizing your concerns, as well as really solidifying the base that you have, especially if you have multiple specialties and you're working across specialties.
That is certainly some great points, and I certainly learned a lot about resident unions today. So I'd like to thank Dr. Latronica and Dr. Almala for their time today. If you have any feedback or episode ideas, please email POMA@POMA.org and be sure to subscribe to the POMA Does podcast series, which can be found on your favorite podcast platform or POMA's YouTube channel. We'll see you next time.
Thank you for joining us for this edition of POMA Does. Be sure to subscribe to POMA Does wherever you listen to your podcasts, and tell your friends and colleagues to tune in. Learn more about osteopathic medicine and POMA on our webpage, www.poma.org, and join the conversation on social media. We're on Facebook, Instagram, LinkedIn, Twitter, and YouTube, or email us at poma@poma.org. We'd love to hear from you. Join us next time for another edition of POMA Does.